Welcome back to Kidney Transplant Conversations, our podcast dedicated to the kidney transplant journey and exploring quality care delivery, inclusion, diversity, equity, and access. I'm Rolf Taylor, your host and series producer. All views and opinions expressed in this podcast reflect those of the participants. In this podcast, we're going to discuss two potential challenges in managing chronic kidney disease and kidney transplants. The first is care when you live a long distance from specialist care, and the second is potential financial barriers. Our guest today, Dr. Silas Prescod Norman, is going to tell us about some very real ways that his hospital center has worked proactively to address both barriers and with tangible results. One thing that has a lot of people worried is the closures of hospitals that has been happening in the last 2 decades and has been exacerbated by the pandemic. The Cecil G. Shep Center at the University of North Carolina has been tracking hospital closures and reports that across the U.S., we've seen around 138 closures in the last 10 years. Southern states and Appalachian states have been particularly badly hit, but this is a national problem affecting all but a handful of states. Every time a hospital closes, someone must travel further for their care, and of course, this is harder for people with fewer resources. So why is this happening? Well, there are a number of factors. One major factor is something called uncompensated care. It's a situation where care is provided by a hospital, but the patient cannot pay and does not have the insurance. In these instances, the hospital has to carry the burden of the cost unless they can reclaim it from state or federal sources. If those sources are limited, the hospital may become financially not viable. In addition, changes in rural industries mean many rural communities have seen a general decline in prosperity and reducing employment, and that has reduced the number of people with good insurance. But these people still need care. Hospital finances may be stretched to breaking point as a result. The pandemic pushed many over the edge. A total of 19 hospitals closed in 2020 alone. Another factor in rural hospital closures is shrinking population in the countryside. Although urban and suburban population centers have grown significantly, by about 8% in the last 10 years, rural communities are mostly in decline. Fewer people results in less investment and fewer supporting services. Now think about that for a special field like kidney transplantation. All of this means there is a shifting landscape for people who don't live in our cities. It's never been more important that patients do their best to be their own advocates and figure out ways to make healthcare work despite the difficulties and challenges. And their care teams are doing their best to support them, as we will hear from Dr. Norman today. Silas Prescod Norman, MD, M.P.H, is a nephrologist at the University of Michigan, working in the transplant program since 2002. And he currently serves as the co-medical director for kidney and pancreas transplant and medical director of the Transplant Multidisciplinary Ambulatory clinics, which see more than 18,000 patient visits annually. Dr. Norman has made a number of contributions to the transplant program, including the creation of a program to transplant HIV-positive individuals and the development of outreach satellite clinics to allow patients greater access to transplant opportunities, and it's this that we'll focus on today. He also serves with and volunteers for a number of organizations related to kidney transplantation, including the National Kidney Foundation of Michigan, the American Kidney Fund, and MOTEP, the Minority Organ Tissue Transplant Education Program, and more recently became an advisor to this podcast, representing the American Society of Transplantation. Welcome, Dr. Silas Norman.
Well, thank you for having me today. Glad to join you, and I appreciate the work you're doing putting on these podcasts. I think it's very important to help get this information out to the public.
So when we think about the provision of kidney transplantation in Michigan, it's a population of about 10 million people. What are the disparities and healthcare challenges that you're most concerned about?
So that's a great question. So there's a number of them. We're certainly concerned about the differences in access to transplant that we see among racial and ethnic minorities. There's also a strong component in Michigan that has a large rural population, where we clearly see differences in access between the urban and rural populations. And perhaps underlying a lot of this is we see substantial differences in access to transplant on the basis of socioeconomic means, particularly among our folks who are impoverished.
And after the Flint water crisis, Michigan got some bad press for public health. Do you think that overall the state is doing well with preventive health and public health?
Overall, I think they are. I think certainly things like the Flint water crisis really exposed how vulnerable some of our patient populations are. At the same time, we've had a great partnership with the Michigan Department of Health and Human Services, which has taken a great interest in chronic kidney disease, in its prevention, and partnered with a number of our local organizations to help minimize kidney disease.
It seems like the Flint water crisis was almost a rehearsal for the COVID crisis in the sense that it amplified pre-existing disparities.
Absolutely. And I think the Flint water crisis, very much like COVID, showed how tenuous the situation is for a number of the people that we serve, and how it doesn't take much to really disrupt their situation, and that they don't have a lot to fall back on when faced with some of these challenges.
So I took a look at the map of Michigan, and you can see just how vast and rural much of the state is. You've got major cities like Kalamazoo, Grand Rapids, and Flint spread out across the south, and then Detroit and Ann Arbor in the southeast corner. And that's as much as a 6-hour drive from the remote north of the state. So the University of Michigan is in Ann Arbor, in the southeast. But for many people with kidney disease needing a transplant, they've had to find their way down to Ann Arbor or Detroit in order to start the process for transplantation. Could you share with us how you went about taking clinics out to the people?
Absolutely. So as you mentioned, the majority of the transplant centers are concentrated in Southeast Michigan, but we have this broad population. And because of some of the reasons we talked about before, particularly poverty, there's a number of patients who just simply didn't have access to the necessary transportation to get across to our centers. And so we thought what made more sense was really to take our services out to the communities. So what we were able to do with institutional support and with the support of our local partners was to move some of our transplant operations to the local communities. And what we did to begin with was we identified some of our local referring partners, and we actually set up our outreach clinics in their offices. And that allowed us to, one, continue the partnership with our referring physicians. It also allowed there to be a place that many patients were familiar with in their local community to come to. And we found in doing this that we saw incremental patients that we wouldn't have seen previously, that the outreach clinics were well received by both the patients and the referring physicians. And with that encouragement and with the institutional support, we were able to build until we had a total of 5 outreach clinics across the state.
And has that also enabled you to extend your network of referring physicians or referring clinics?
It has, in the same way as the majority of transplant centers are concentrated in Southeast Michigan and around large urban centers, the same is true for nephrology care in general. And what we find, particularly as we go into northern Michigan, is that there's very little nephrology care. In fact, we tend to know the names of the handful of nephrologists that are really trying to manage a huge geographic area of patients. And so we were fortunate to already have those individuals as referring physicians to our center. By doing outreach clinics, what we really allowed them to do was to send us patients who were otherwise medically appropriate for transplant, but based on their care and knowledge of these patients that they knew really didn't have the means to get down to our center in Ann Arbor. And so it certainly has allowed us to grow the number of patients that are available for the referring physicians to consider for transplantation. I think one of the most fascinating things we've realized about these outreach clinics and realize about the hunger and the desire to have these clinics in the communities is that the patients know about these things. One of the things I think is been almost funny is that as we would plan a new outreach clinic and we would say, we're going to think about going to Midland, before we'd really made any concrete moves, I would have patients coming to me saying, hey, I heard that you're going to have a clinic in Midland. And so it's out there and the patients know, and they were ready for it. If we wondered if the need was there, they were letting us know the need was there and they were ready.
So they say if you build it, they will come. But as soon as they knew you had started building it, they were ready. So let's talk about the clinics and how that works when you're taking a multidisciplinary team out there, because it's not just nephrology, right? You're also taking other specialists. So who do you take out to the clinics?
Absolutely. So with the caveat that COVID has changed things for us a little bit, but in order to evaluate people properly, we need nephrology, we need surgery, we need social work. In addition, we like to have a nutritional evaluation, and people need our financial coordinators to make sure that their insurance and resources are in place. And so when we go to our outreach clinics, typically it's a nephrologist, a surgeon, and a social worker as the core team. And very often we also have our financial coordinators coming to clinic as well.
So let's talk about finance for a moment, because obviously finance can be a major barrier to, accessing life-saving transplant surgery. What kinds of help are there if you know where to look? And I'm sure your financial coordinators know where to look.
Absolutely. So I think there's two or three things for people to know. One, as you alluded to, there's a lot of assistance for people out there. And so one of the things we really try to emphasize is that as much as possible, people's financial resources or their perception of their resources should not be a reason not to pursue transplantation. We, in general, want to have every person who's medically appropriate for transplantation have an opportunity to have a transplant evaluation and have that considered for them. There are a number of ways we can assist people. One of the simplest ways our financial coordinators can assist people is to look at their current insurance plans in light of transplantation and help them say, you may want to change this plan or this plan because your particular insurance plan might work well for you now, but given what we know is coming up for transplantation, you're going to be looking at XYZ copays if you stick with this plan, or this plan is going to fail to cover XYZ. So let's make these changes ahead of time to minimize your out-of-pocket costs. And that can be one of the most helpful things. We help make sure people have the proper secondary insurance, again, with the idea that transplant medications can be very expensive. And so we want to make sure that people have the necessary coverage in place so that they don't have large bills. We can help connect people to a number of community resources, places like the American Kidney Fund that helps connect people to resources and helps people afford their insurance premiums to help facilitate transplantation. And then importantly, post-transplant, all of the major pharmaceutical companies that we work with all have programs to help people better afford their medication. And so really, we want people to really be able to focus on their medical care and really let us help support them in making sure that it's affordable for them.
You mentioned that you're encouraging people to look at their insurance and change their insurance. So you're encouraging long-term planning. Has that become easier because of the Affordable Care Act, setting up more insurance exchanges and making it easier for people to change their insurance if they need to?
I think definitely. We certainly have patients who are explicitly on some of the plans that have been made available through the Affordable Care Act. And I think certainly in transplantation, the more we can expand access to quality insurance coverage, it only helps our patients. And really, when we think about the cost of transplantation and the cost of dialysis, it actually is helpful to society in general that we're able to move people from dialysis, which is extraordinarily expensive, to transplantation that's not cheap, but is substantially less expensive over the long term.
And then covering the copay costs, you would encourage people to look at things like copay insurance as a supplementary insurance.
Absolutely. So supplementary insurance, and then, and again, there's a number of programs to look at specific medications that people may need. And there's a number of ways to have those covered. There's a number of programs that have means tests that are income-based, cutoffs of sliding scales for cost to help patients afford their medications, to make sure that every transplant that gets done, we can support and make sure people have the best outcome possible.
And what I did notice is that there is a society for transplant financial coordinators. So I double checked, and I think we're going to have to ask them if they'll come and join the advisory committee for the podcast, and we can maybe get a financial transplant coordinator to come and tell us, firsthand what they're doing. In terms of your outreach clinics, after you've done the surgery, it's vital that patients look after their grafts and have regular checkups and maybe fine-tune medication, maintain healthy lifestyles. Have the outreach clinics been able to facilitate better post-surgery engagement as well?
I think so. A couple of the things we've been able to do are we want everybody to keep track of their blood pressure, their blood sugars, if that's appropriate, early on, their urine output and some other things. And so we have a lot of education of patients to let them know the expectations ahead of time. One of the things outreach has been good for is, one, for our patients who are more than a year out, we have the opportunity to see them in the outreach clinics. And that just facilitates everything because their transportation time as well as distance is cut down. It often facilitates their support people being able to join the visit with them. And that way we make sure that we're getting more clear, accurate information, that the support people really understand what's being asked of them. The other benefit we found by being in the office of a number of our referring physicians is that those physicians can just physically come down and see us while we're there, and we can run through patients together to make sure that we have a comprehensive care plan for each patient and that we're all on the same page and working together for the betterment of the patient. So they've definitely been helpful.
So then you have the whole team together, including the primary care team or the referring team, and you can get into alignment for the care plan.
Absolutely. And I think one of the things that patients like to see is that all of their providers are working well together. And so I think it's very encouraging for the patients to know, in this case, that two of their physicians are directly speaking to each other about their care plan. And so I can say to the patient, I spoke to Dr. Such and Such, and we agree that this is the plan, and they can say the same thing. And so I think that is reassuring to the patient that they're really getting sort of one comprehensive set of care.
And what sort of picture are you getting in terms of the outreach clinics impacting disparities?
So I think that's a terrific question, because you could locate outreach clinics anywhere in theory. So one of the things we did was looked at the map of Michigan, similarly to what you did, and tried to say, of course, where are areas of markets from a business standpoint that might be good to move into, but also with a very deliberate eye of where are our underserved populations, and can we make those two meet? From our standpoint, we could see that the west side of the state was relatively underserved for transplant, and so that was a place to go. As we move north in the state, as we talked about the limited amount of nephrology care that's there, we know that that's an underserved area of the state. And as we get north, as we get west, we're also getting into the rural populations of the state. And so we were able to not just go where there's a market share in particular, but really go where the patients are, where they need us. And so we deliberately tried to co-locate our clinic in areas specifically where we thought patients had decreased access to transplant opportunities.
And I know that in the course of facilitating a transplant, you get to know your patients pretty well. So is there a case study or story that comes to mind that where someone really obviously benefited from the outreach and provision of transplant financial coordinators?
There's probably multiple, but I'll tell you this one. So we have a gentleman who lives in northern Michigan, up near the Sioux. So in the upper part of Michigan, their drive to our transplant center is about 7 hours. And so we have a clinic currently in Midland, which is in the middle of Michigan. And so it's not a short drive, but a 4-hour drive is meaningfully different than a 7-hour drive. And so being able to evaluate this person in that clinic allowed us to see somebody that we likely would never have seen simply because of the distance. In addition, this is a person who had limited transportation, a limited social support network. And again, if we were just making them come all the way down to Ann Arbor with that network, in the past, we would have said, this is probably not doable because realistically, logistically, this is not going to work. You don't have the the support in place, the transportation in place to make this work. But because of the outreach clinics, we were able to facilitate that. And then in terms of the financial aspect of it, this is somewhat of relatively modest means. And so getting finance involved early on allowed us to really make sure, again, insurance-wise, we were in a good place, that we had thoughtful plans about what we were going to do around support and transportation, that we could think creatively about some of the visits, and that maybe we would do things exactly the way we typically do per protocol, but can we come up with a circumstance that's going to work for that patient? And we were able to successfully get this individual transplanted, and they're doing well. One of the things for us as a large, academic medical center, on a school campus like a lot of centers are, our historic model has been, as a tertiary care center, people coming to us, and we just expect that people come to us. And I think to the benefit of the patients, I think the big cultural shift that we've had over the last 10 years or so is the thought that we should really be bringing services to the patients in the communities where they live, trying to break down barriers to access to transplant and making it as easy as possible for people to get transplanted. And it turns out that putting the patient first, thinking about the patient's interests first and what might be best for the patient experience, you can do that and still have a financially successful center. And so, this is not necessarily doing care at cost. There's a win-win here, which is that the transplant center and the hospital wins in delivering this kind of care, and patients win. And we're able to move, I think, closer to our mission, which is really to get as many medically appropriate people transplanted as possible.
Right. No, that's great. And what year did you start with the outreach clinics?
Our outreach clinics are a little more than 10 years old, a little before that, actually. So it must be about 12 years old at this point.
Yeah. And then along came COVID. Suddenly, it's much harder for you to travel and to do face-to-face outreach. Can you tell us how you switched to more of a virtual care and how you managed to maintain the volume of transplants since COVID came along?
Absolutely. So like a lot of transplant centers, we had a roughly 2-month downtime where we stopped doing evaluations that were non-urgent at the early height of the pandemic. But after that, we and the rest of the hospital system made a very rapid transition to virtual care, including in transplantation. And what that allowed us to do was to continue to do transplant evaluations. And so what we do now is our initial evaluations for everybody are done virtually. And that allows convenience for the patient. It allows their support people to be often on the video call as well and hear the information. We don't cut into people's work time nearly as much. And then having done that virtual evaluation, and we do the medical evaluation virtually, we do the nutrition evaluation virtually, and the social work evaluation virtually. And so with all that done, for the patients who otherwise look like they're going to be good candidates, then we can subsequently set a time for patients to come to their face-to-face evaluation. That face-to-face evaluation either happens in Ann Arbor or at one of the established outreach clinics. So that happens. And one of the great things for the patients, I think, has been in changing the way we do things. It used to be in the outreach clinic, the patient would be there for 4 or 5 hours. It used to be when they came to Ann Arbor, it was roughly an 8-hour day because they would see everybody and just the way the day was set up. In doing a lot of the history gathering virtually at first, in having social work virtual and having nutrition virtually, those are less people they need to see. So when they come see us in outreach, then they're really just seeing the nephrologist and the surgeon. Those are half-an-hour visits each. So we turned what was a 5 to 8 hour day for the patient into a 1 hour day for the patient, which has huge benefits for the patient and for us. The patients are often, more receptive to the education and the messages we're giving. As you might imagine, as people sort of approach the end of that 7 or 8 hour day, they were kind of running out of steam a little bit. So I think it's been a lot more patient friendly. And by breaking it up, it does mean a few more visits, but we can work around people's schedules and we give them sort of more digestible chunks of education about transplant. So I think it's worked very well. And as evidenced by our volumes, we're up more than 10% year on year So at least as evidenced by the volumes, this has worked well.
So you've been able to keep things moving that had been previously set up even during this time of the pandemic. And in the background, I know there's some policy changes were made for things like reimbursement, which means that having a telehealth visit means you get the same reimbursement as a face-to-face. Is that going to continue, do you think?
So I can't say for sure, but I would have to imagine the answer is yes. As you mentioned, the current parity between the face-to-face visits and the video visits was really under the COVID authorization related to COVID. It's been reauthorized at least once. And I anticipate because it's worked so well, I can't imagine undoing this. It's been such a benefit for the patients. It's been an improvement in efficiency for the transplant centers and other parts of the hospital. So I certainly hope the billing parity has continued. I think it's been a huge benefit.
Have you experienced any kind of digital divide issues that have prevented people from getting access to telehealth?
We have. And so in fact, although we do the majority of our visits as video visits, we do have a handful of visits that are still phone visits right now. And those are for people who, in fact, don't have access to a smartphone or an iPad or some device where they can do the video visits, or often more frequently is that they don't have access to broadband. And that's really the limitation. Certainly when we've done our visits, even some of the video visits, people are clearly at Panera or some other area to get access to wireless, which is great and creative on their part, but highlights that as we push for this, we really have to be cognizant of the patient groups that we're taking care of. One of the things we started exploring is partnering with our local physicians, those folks that we have in the outreach clinics that we're working with, work to partner with them to see if we can't provide devices so that people can do video visits from those offices as one way to still remove that transportation barrier, still allow people access to virtual visits without adding costs, trying to get broadband or upgrade phones just to do medical care.
So they can host or facilitate a video visit on the premises, and then that saves people having to do it from a public place.
I think so. And that allows, again, these physicians, these local physicians are very invested in the patients. They're very invested in helping move these patients towards transplant. And as we discovered in the outreach clinics where the physician said, yes, come, what do you need us to do to make this happen? I think this is just one more step in how do we, as really one team of physicians and care providers, work in the interest of the patients to help move forward and increase access to transplant.
It's been really wonderful hearing the story of your outreach clinics today. Thanks so much for sharing all of that with us. And it's clear you've made an impact, and I'm sure you're going to continue to make an impact in Michigan, in particular in reaching out to rural patients.
Well, thank you. I have a great team that I work with, and with that team that's really focused on patient care, we've been able to make some great headway, and I hope we can continue to serve our community. And I so much appreciate you having me on today and taking the time to just hear about how we've been able to improve our patient care.
Absolutely. And I'm sure it'll be an inspiration to listeners, whether they're patients or whether they're professionals, to hear what you've been doing there. Any final words you'd like to leave our listeners with?
Sure. So one, I would just like to say, if you have advanced chronic kidney disease, for almost everybody, transplant is recognized as the best therapy for kidney disease. And we want everybody to have an opportunity to be evaluated for transplant. We want to let people know that they can refer themselves for a transplant evaluation. And so if your physician or care provider has not referred you, you can refer yourself directly to a transplant center for evaluation. So we encourage people to do that. Don't let the finance concerns deter you from exploring transplantation. We have a lot of ways we can help people. And, finally, I might say that care of transplant is a partnership between you, your local providers, and the transplant center. We're here for you. We want to help take care of people, and we just encourage people to reach out.
Dr. Silas Norman, Thank you so much. It's been fascinating. And please join us again on the podcast at some point in the future.
Absolutely will. Thank you for having me.
And thank you to our listeners for joining us today. If you enjoyed the podcast, please consider sharing it with others and subscribing on any of the leading podcast platforms and smart speakers. We also thank the participants and advisors who helped create this podcast and our underwriter, Veloxis Pharmaceuticals. Join us again soon for more kidney transplant conversations. Until next time, take care and be well. Copyright Project Advocacy 2021.